Hello to all. It's a great pleasure and honor to be in this course. And I would like to thank to the organizing committee with the all work they have done to gather all these people interested in the study of synovitis. And I'm going mostly to share my experience. It will be a really technical, also a technical presentation. Let me just, okay. In this contest, there are no conflicts, of course. Most of you don't know me, so I'll just share my background so that's for you to understand why we have our experience. It's a little bit different from the other centers, probably. I'm a rheumatologist with when I started doing ultrasound-guided biopsies in 2013, I already had experience in ultrasound and ultrasound-guided procedures. We have independent techniques sub-department in our department, and we are doing a lot of ultrasound and ultrasound-guided procedures. I usually, in a normal week, do at least 10, 15 ultrasound-guided procedures, okay? I don't do biopsies every week, but do it quite often. And a lot of ultrasound, maybe 50 to ultrasounds per week. So there's some experience on that, and that helped because my learning curve is a bit different. When I started doing the biopsies, I learned with my fellow, with Vasco, that was doing a fellowship in Mileland. So Vasco went 6 months at Mileland. He learned how to do the ultrasound-guided biopsies with Stefan Keldenly mostly. So when he came back to us, he taught me to do the biopsies. I didn't go to London myself. Of course, afterwards I met Stefan and Constantine. And so.
Came to you.
Yeah, so it's a bit different experience. And apart from that, I have had experience on blind needle biopsies with the Parker-Pearson's that you have seen, that big Parker-Pearson's needle, and we have had experience on that in medium and large joints. So we adapted that experience, all that experience, to the ultrasound-guided needle biopsies, as you will see. And we have had also, and that helped me in some joints, experience in fluoroscopy guided injection, because back in 2008 our ultrasound machine was not that good, and we had to do when I was in my residency, we had to do some joint injections with fluoroscopy. Afterwards, after maybe 2010 or so, we just left the fluoroscopy because we have had a better equipment. Sorry for this, but it was just to understand why I'm here and to know me and to understand the context of my experience. Okay. So this is probably one of the most cited papers here, and just to show the different biopsies that can be done and are still done nowadays: the Parker-Pearson's, the needle ultrasound guided, the portal and forceps ultrasound guided that we are not doing in our department, and the minimally invasive arthroscopy that we are also doing on the knees in our department. Elsa is doing it. And that's also the reason why we don't have that much knee ultrasound-guided biopsies. So I will pass on that. We have just discussed that in other sessions, and this is one of the important papers that was also already cited by Carlos Hire. On the validation of a minimally invasive ultrasound-guided synovial biopsy with the portal and the forceps approach, with a comparison with the arthroscopy, and it was already discussed. One of the most important, I guess, ultrasound-guided biopsy papers with needle was this one from Stephen Kelly, and it has shown us, as you have seen, they have biopsy mostly wrists and knees, but also some other small joints. And they have shown, sorry to move around fast because all of this has been discussed and I don't want to bother you. I want to pass to the more technical part that I think it's more important that you've never heard here in this course. But just to remember, because this is important for my talk, that he has shown in large joints, and those included here are mostly exclusively knees, just to remember that. He has shown that the percentage of gradable biopsies was bigger the joint. So knees, better than wrists and ankles, better than MCPs and PIPs, okay? And the same for the grayscale. So the more amount we have, potentially, the more amount we have of good material. That's not only science, but common sense. Okay? So, and this was also an important review already previously cited by Francis Amby, and that compared the four techniques that I mentioned. And we contributed with the Parker-Pearsons, with knees, mostly. And also ultrasound guided and also arthroscopy. And the same trend, so when we are looking at knees, ultrasound guided, the quality also seems better of the percentage of gradable biopsies in different centers, so which is important. But what it seems, it's of course the blind needle biopsy seems less reliable than arthroscopy or ultrasound guided, but in fact with the Parker-Pearson we get more material because the Parker-Pearson, it's a bigger, not that much quality material. You also pick up other stuff such as capsule and sometimes muscle when pushing it out, okay? But the quantity of synovium it's bigger. And when compared with the ultrasound guided, the arthroscopy yielded higher amount of tissue. And again, the study included knees, wrists, and ankles as medium joints, and MCPs and PIPs as small. And this is the algorithm that was discussed before of Stephen Kelly. If you are doing studies on RA and trying to decide which joint to biopsy, I'm sorry, it's probably not very easily seen, but you would prefer to start with the medium or large joints if you have grade 3 synovial thickening in these joints. If not, you would prefer a small, medium or large joint with at least grade 2s, a synovial thickening. And if not, a medium and large with grade 1. And then, if you have nothing, no option, you would go to any joint with grade 1. And then for the smaller ones, it can be really, really tricky. Well, we all know the risks, but I think it is important if you decide, and someone asked before, well, sometimes in clinical practice, we just have to biopsy any joint. Yeah, in fact, and that's what we felt. When we start doing this technique, of course, we also started to do it mostly in the wrists, as Vasco learned in my hand. And we did it for clinical trials that we participated in R4RA. But we started to need to do biopsies in patients with monoarthritis of the hip. Wow. We have had some experience with ultrasound guided with Parker-Pearsons before. Not the best experience of all. But and since our orthopedic surgeons usually are not that collaborative when we need to harvest material to exclude infection, and we have this wide 4-decade experience in our department of doing biopsies, so we are very interventive and we began to also do in biopsies with ultrasound guidance, knowing that we had that experience in injections and so on, as I explained before. So knowing the anatomy, knowing the risks, the global risks, the risks that are transverse to all the joints we are going to biopsy, mostly you have to really know the anatomy to take care of this neurovascular lesion. This is probably the most important and site-specific risk that you must be aware when you are going to approach any joint, okay? So this is our needle, the one we use. It's not very different from the others. It's just another brand, okay? So it works the same way. We have the 16G, sorry. The 16G, as you may see, with one click, the throw opens 1 centimeter. With 2 clicks, opens 2. We mostly use the 1. Opening the 2, as someone said before, you bend it a little bit, and then you probably will have to change the needle in the middle of the procedure, which is not nice, because they are not that cheap, okay? Just put the video. It's just to illustrate what you have seen before in your hands, but this is how it works. And one important thing, to get good material, when you open the throw inside the joint, you always have to push it against the synovium before you shoot the throw to harvest the material. So let's go from joint to joint, and what I did was to apply what I did to inject my patients to the biopsy. So elbow, how do I do it usually? Of course, the easiest way to inject the elbow without consequences, with no neurovascular consequences, is to go posteriorly, laterally through the epicondylar, the lateral epicondylar, when there are no neurovascular structures. But for biopsy, that may be a little bit tricky, because you cannot bend and throw the throw of the needle against the synovium, as I will explain to you. So the best way, I guess, we can do it, although there are some neurovascular structures not that far, so we have to clearly identify them in order to do this safely, okay? So, but I still think it's the best way to approach the elbow and to do a biopsy. It's the lateral way, proximal to the as you may see here, and just below posteriorly to the radial nerve, okay? So in the proximal fossa, but posterior to the radial nerve. And it is really, really important that you tell your patient to hold a supination, because if you will pronate, what will happen is that he will, and sometimes when you have pain in the elbow, the patient tends to pronate the elbow, okay? And what will that do? The radial nerve and its distal branches, such as the posterior interosseous nerve, will go anteriorly, and you may pick it up in the biopsy. So you pay attention. We are doing a biopsy of the elbow. Always be sure that your patient maintains the supination. So approaching laterally, just posteriorly to the radial nerve, through the extensor carpi radialis, long extensor carpialis muscle, and the brachioradialis. These are the muscles that we are going to transverse. And posterior to the radial nerve and the recurrent radial artery that you can show close to the nerve. The posterior approach, as I told you, although safer in terms of joint injection, for doing a biopsy, and since we have to push the needle against the synovium, it's not feasible, I guess. I tried it once, and I didn't like the experience, not the tolerability, but mostly the quality of the material. It was not easy to harvest. So this is I'm sorry, probably it's a bit too dark, but this is a short axis image of the elbow, proximally to the joint line, so proximally. This is lateral, this is medial, and it's not very easily seen, but you usually see the radial nerve. So you will, approaching this way, you will pass too close to the radial nerve. If you do a good supination, you can go almost horizontally, and you go far away, 2 or 3 centimeters of the radial nerve, okay? One thing important, if you do a lot of anesthetic there and through the pathway, the patient may we have had one case, the patient had a transient wrist drop due to the quantity of anesthetic, okay? So be aware of that, okay? And then the procedure is, as all ultrasound guided biopsy procedure, you open the throw, you push it against the synovium, and you can do it in the directions you want. Of course, avoid the bone, avoid the cartilage, okay? Try to pick up when you see what you think that may be synovium, okay? The shoulder, as in the elbow, we have done some elbows, as I will show you later on. The shoulder we have not done that many because it's not that frequent to need to biopsy a shoulder, but we also have done it in demand of clinical practice to exclude infection. And when we had to approach the shoulder, we did it as we do the joint injection. So we can do it with the patient seated, but it's a biopsy. I usually tend to do the biopsies with the patient or lying supine, or in this case in lateral decubitus, with the shoulder to biopsy upwards, okay? And no risk of vagal discomfort in the procedure and the patient falling on the front of you, which is not very good. So also approaching from laterally, in this case from superiorly if the patient lies laterally, and as we do for the injection. So this is laterally, the needle comes from laterally to here, we open the throw, then we push, and we can do it this way. It's not very handy because we have to do it in this position, of course, but it is possible to do also. And it is easy to anesthetize. Of course, when we are talking about big joints, such as the shoulder, we have to do a considerable amount of lidocaine inside the joint, about 10 to 15 milliliters at least, usually, okay? As Laurent already said before. The tibiotalar, and also not that easy joint, but now with practice we find it easy. We inject a lot of tibiotalar joints, in fact, spondyloarthritis, rheumatoid arthritis, and so on. And I started to use this approach that I find easy because we can again see easily the neurovascular structures, the fibular nerve, the deep and the superficial fibular nerves. Sometimes the superficial is not very easily seen, but is very superficial and not along the pathway, so it's not a problem. But the deep is very close to the pediosus artery, so you can easily identify them. And I found the best approach for the tibiotalar, the lateral one, just below the extensor digiti common and the peroneus tertius when it exists, because it's not it doesn't exist in everyone. So this approach, okay? So the patient lying supine with the knee flexed at about 90 degrees, and it helps that the tibiotalar it's a bit extended, okay? With the plantar flexion, okay? To open up the joint a little bit. And again, with correlating with the ultrasound, this is the longitudinal view, proximal distal. This is the transverse. In fact, this is an image of a tenosynovitis, of an extensor common digiti. Okay, but the objective is just to pass below this tendon. Okay, this is not a huge synovitis here, but here it was a grade 2 synovitis, so it was not easy, difficult to approach. Okay. And usually the pediosus artery and the nerve are around here, okay? You can use the Doppler to help you. They are always very close. And the nerve may be superficial or lateral to the artery, so it can not be that easy to see it. But if you are sure that you are away from the artery, you are probably also away from the nerve and inside the joint, okay? But usually you can see it. And then the principles are obviously the same as I mentioned before in the tibiotalar. Okay. The knee. Usually we approach it as we did with the blind biopsy. So in the suprapatellar pouch, as we do the joint aspiration probably, okay? It was in the same way. And we do it with the same approach. We are not doing that much of the knee because we are doing it mostly by mini arthroscopy. Elsa is doing most of the knees. But technically it's not that difficult to apply. Well, okay. And the hip. Well, the hip, it's tricky because it's deep. We have experience in injection.
Can I ask a question about the ankle?
Yes.
Some of us that were brought up when we did blind needle injections without ultrasound.
Yeah.
We went anteriorly.
Okay. Yeah.
Laterally to the tibialis anterior tendon, and say that's a big cavity. Is that some reason why you prefer
Yes.
lateral approach?
Yes. There is, and the reason is that we have to push always the open throw against the synovium, and doing it anteriorly. If I do that anteriorly, I will go through the cartilage probably or the periosteum after opening the throw, and that's the reason why. And apart from that, of course, if we go, let me push a little bit back. If we go anteriorly, we also
Not exactly in the middle. Like
yeah, but when we did the blind biopsies, and I did some 10 years ago or so, we also approached the joint anteriorly in order to anesthetize, but we did it laterally to collect the biopsies. So we modified a little bit the technique using it at ultrasound. Apart from that, that's why I explained. To push the open throw against the synovium, I found the lateral approach the easiest one, and I'm always able to see the neurovascular structures, which are always the major concern when I'm approaching a different anatomical location. This is not published. This is creativity. Okay. Okay. Hopefully it will be published when we have more numbers. In fact, we have submitted a paper that I will show some results next. So, in the hip, well, what we did in the hip, yes?
No,
Time.
just saying that you were in the knee.
Okay. In the hip, we have had experience weekly of injecting or injecting both steroids or hyaluronic acid in the hip. We usually do it for just injection in the longitudinal way, so putting the probe along missing the word. In this way, in the longitudinal way, as we see the joint in ultrasound like that, so doing this and injecting. But again, if you want to open the throw and push it against the synovium, this is not a good way. We are too deep, we are too steep, and we are not collecting any synovium. So, what we did and thought that could be useful, and we had quite success in the biopsies we did this way. There were not that many, 4 or 5, but they were extremely well tolerated. But we modified the approach that we did 10 years ago with the fluoroscopic guided hip injection, that we approached it laterally. So I did the same, approaching laterally, just posterior to the sartorius muscle. Okay, it's a long way. You have to use the low frequency. Not the convex probe, the linear is fine, but it may be helpful to use the virtual convex setting to have a wider field of view, okay? Because you will have to of course, you anesthetize the skin and so on. The major concern with neurovascular structures is the femorocutaneous nerve. Sometimes we touch it and we don't see it because it's a very, very thin nerve. It's not that easily seen, and you sometimes touch it. It's not a motor nerve, but it sometimes passes close to that location, as you may see. But the noble neurovascular structures, which are more medial, they are far away, so we can control this risk quite easily doing this approach. If you follow all the way the trajectory of the needle, okay? So going laterally up to this point, and once you're inside the joint, you put a lead docking to see the capsule distend and so on, and then it's the same. Open the throat, push it against the synovium, and harvest the material. Okay. What I found more difficult doing this by the needle biopsy, since we are so far away, we use the 10 centimeters. Some patients' 10 centimeters needle is not enough. Okay, that's an issue. Or you have just to push the subcutaneous tissue along the way to get there. But that's one of the major issues. Probably we need a bigger needle for some patients. And since we have to do that bending and pushing up, we have to apply more force, and sometimes the needle bends a little bit in this process. And that's why I think in some hips, apart from collecting synovium that we did, we also collect some muscle along the track and some skin when going out because of the bending of the needle. You saw the needles. If the throw bends a little bit, you stay with one tip that it's not that smooth when entering. So you can pick up some muscle along the track. That's a problem that we are trying to optimize in order to approach these bigger joints with the larger trajectories, such as the hip. Okay, that's not a problem, obviously, in wrists and PIPs, MCPs, and so on. There are other problems, of course. Okay, so this is submitted of our experience. We have more experience now than this one, but just to be aware, we have biopsy 2 shoulders, 7 elbows, 3 hips, 5 knees. So we have not that much experience, as I explained you, with the knees because of the arthroscopy, and mostly we have experience in wrists and ankles. We don't have that much experience with the small joints, and in small joints we also have clinically to biopsy some other joints, such as the navicular-cuneiform in the tarsum and the sternoclaviculi to exclude infection. The wrists, many of the wrists biopsy were for research also. Okay. And the tolerability, apart of being small or big joints, the tolerability is about the same. I'm not showing that results, but it's a good tolerability as much of this procedure. The immediate post tolerability, the discomfort, as you may see, only 4% intense pain and mild pain 6%, moderate discomfort 20%, but clearly well tolerated, very likely to repeat and likely. So it's a bit like what was presented before. Other experiences are similar to ours. And also we have the experience of the pain and swelling improving after the biopsy. There are many explanations for this. They were presented yesterday. Changes of the treatment and so on. The lavage that we somewhat do with lidocaine and so on may improve a little bit. We don't know. And even we saw a trend to the decrease in the grayscale synovitis. Was not statistically significant, but we saw that. And yeah, large joints. I have to remind you, a lot of hips. Some hips, some shoulders, so not that many knees. So the percentage of gradable samples in our large joints is not that good. So we were using it, but in the medium joints was the best of all, and we included not only wrists but also the tibiotalar joints. Of course, we saw a tendency of better percentage of gradable joints along the operator experience. And this is the percentage of gradable synovial samples per synovial sample, okay? And what we considered gradable was the same that Frances Amby shown in her studies. So the presence of a lining layer was decisive for that. So that doesn't mean that some of these samples were not synovium, they just didn't pick up the lining layer. So to end, and thank you for your attention, I must say. If we have experience in ultrasound and ultrasound guided procedures, you can probably, with some teaching, of course, implement this technique. We have to have a thorough knowledge of anatomy and ultrasound to do it with confidence. That's important, of course. And probably, and we don't know this by science yet, there are different learning curves per joint. Yeah, probably there are. And probably we will have to optimize some aspects to approach some joints, such as the hip, for instance. Okay, but independently of the joint, this technique seems very, very well tolerated, and that's important also. And just like to thank. This is not the work of just me. I think I had some importance on that, but of course my boss, which is sitting there, was important. Our technical department responsible, Fernando Saraiva, also did most of the joints. In fact, of all the biopsies, either me or our technical department rheumatologist were present. So we did most of them. Of course, Vasco participated with either me or Fernando. Elsa, also important for the arthroscope. Rita, which is seated here, also participating in some biopsies. Nikita, also também. And here, a name of an older rheumatologist, which did the first blind biopsy and was very important for all the experience in blind biopsies that we have in our department. He indirectly also was important by this presentation. And of course, without the help of the colleagues from Queen Mary in London, Constantinos, Stephen Kelly, Frances Amby, we wouldn't be able to be here also. And thank you for your attention.